And there was nothing wrong with this initial commentary. And I know it reinforces some of the stuff I'm sure you did with Dr. Robbins. But I found the illustrations and their explanations a little clearer for what I want you to understand about bone. And that's why I sent you this 6A, which we're going to divert to, and we're going to start roughly here, just sort of concluding gross anatomy in that same area. If I'm entitled to teach you about anything, it's bone. I mean, they don't let you operate on bone for 25 years unless you know what the hell you're doing without bones. So I know my way around bone. And to try to give you some ideas and some things that we do, and to understand this remarkable bit of tissue that we have between bones and muscles, all this power and strength that we have that are there. The difference is the kind of bones. Our focus point today is going to be the long bone. When you study bone, the anatomy and physiology, the long bone is the best model. So we focus on that. And we have all the other shapes and sizes are interesting. Effectively, bone is divided into two sections. You have cortical and cancellous bone. Cortical or compact bone is that hard shell. The thicker the shell, the stronger that bone is. Your extremity bones are all like that. So think of an aluminum tube that you might, if you're an aluminum tube, you're putting up an awning or you're putting up a tent. Think of how, even though it's hollow in the middle, how much tube there is. If it's aluminum and it's relatively thin, it might bend fairly easily. If it's stainless steel and that rim is a bit thicker, it's quite a bit stronger. Bone's more in that line of things. Yet it has complementary features of both. It has flexibility and it has strength. That's the way to look at it. And the interior of that tube, it's called cancellous or spongy bone because it looks like a honeycomb, as you will see here. This is, as you can see from the slice, that's typical skull. We call flat bones. They're like a sandwich. They have cortical bone on the outside and cancellous bone on the inside. For blood forming, which is one of the jobs bone has, although it's really more appropriately discussed in AP2 when you do the cardiovascular unit on blood. Effectively, that's the bone marrow that you and I, basically, most of us are at our adult frames. The red bone marrow has disappeared for the most part from our extremities, with the exception maybe of the upper portion of the humerus and the upper portion of the femur. Other than that, that bone marrow has been replaced by fat. They call it the yellow bone marrow. And it's not about fat storage or anything like that. It can convert back to red, and people are anemic if they're not making enough red blood cells. And those are things like that. But the reality is that if someone's trying to donate bone marrow, has to receive it, or they're trying to analyze the bone marrow for leukemia or severe anemias, all of which the bone marrow is highly relevant. That's its job. You access it in the flat bones, particularly sternum and iliac crest. Because they're right under the skin, a little bit of fatty tissue, and basically open it up and, for all intents and purposes, punch a hole to either suck it out or put it back in, depending on what the needs are. And so this honeycomb is about surface area. And you're going to see it provides a lot of structural strength. They use the analogies of like underpinnings of a suspension bridge, a big suspension bridge, like and nothing else in Pittsburgh. They're the city of bridges. They're small, but they're bridges. Come from the land of Verrazano Narrows and George Washington Bridge. Big bridges. So our really focus point is less about those. And you learned a lot about the different categories. And is this a short bone? Is it a long bone? What makes it? That's that. Okay, long bone. Okay. The focus point, the shaft is called the diaphysis. The ends are called the epiphyses. Epiphysis being the singular. Their blood supply, and that's the beauty of bone. Bone has extraordinarily generous blood supply. And all of these bones from a cartilage cell come from a cartilage shell. The cartilage is always hyaline cartilage. That's what's left that makes up the joints. The ends of the bones, where they articulate or come together to form a joint, are coated in a very thin coating of what's left of this hyaline, beautiful white glistening cartilage that's there. All right. So we look at the blood supply. Cartilage has none. And indeed, what makes the transformation, because all of our extremity bones, okay, all not a few, all of our extremity bones come from cartilage. Okay? And when blood invades them, effectively blood destroys cartilage, it erodes it, and starts to transition into bone. If you're an athlete, if you're just sprain your ankle badly enough that you go outside and you get blood in, so you don't have to be an athlete to do that. Blood on cartilage is an erosive agent. If you do that enough times and there's enough erosion down the road, and we can talk 25 years, get something called post-traumatic arthritis. We talk about that in the arthritis unit. It's another one of those things I know a lot about. Okay, and I'm flattering myself, but it's I always qualify if I'm if I have a lot of experience or not about certain things. So it's just so terribly important to understand that if you can just put the bone together and keep it from moving around, the blood supply, as long as it's intact, that bone's going to heal. It's the beauty of bone. Very, very interesting tissue. Very, very interesting piece of organic material. So the diaphysis, the tubular shaft, the long axis of the bone, they're all in different positions anatomically, so we just talk about long axis. If you want to think superior and inferior, proximal, distal, I don't care. Whatever makes it work for you. Okay? Compact bone surrounding a cavity and yellow marrow in the adults, because now it's not really doing bone formation, blood formation rather. Yeah. And as you get inside of what we call the cortical bone, you begin to see a lot of this trabecular cancellous spongy bone surface area for some lining cells, and on top of that lining, draped all over it, is the red bone marrow for certainly most your early years to really be the area for blood cells being. And you'll see that all blood cells, red cells, white cells, platelets, they're all born in the bone. All. They end up maturing in different places, but all born in the bone marrow. So the epiphyses are the ends. They show up later. They begin to take shapes associated with eventually the joints that they're going to form. They have a little bit of the compact bone, but in those ends, it's almost all this spongy or cancellous bone. That's what remains cancellous, with some blood formation in the upper portion of the hip, the femur, and of the humerus as adults, interestingly enough. And again, what's left of the cartilage, and it's just a thin shell, comparatively speaking, is allows our bones to move effortlessly, wonderfully. Let's take it from somebody who's operated on any number of joints over a 25-year surgical career. White, beautiful, glistening cartilage we see in some of the slides as we go through them over this unit and the bone unit and the joint unit. It's remarkable. By the same token, when it's deteriorated into arthritis, it's just as remarkable to see how bad it looks. Either rock hard or super soft. And then it'll get us into our discussion of different arthritis types. Okay, and when we'll talk a little bit, not today, but next time, about how bone grows. That's one of the focus points of next time, called the epiphyseal plate or growth plate, which most of you don't have anymore. Some of the guys may, most of the girls will not. Pretty much by age 18, you're pretty much, as far as you're that way. There can be other changes, but you're not going to get tall. I've been this height since I was in ninth grade. I demand a recount. Vertically challenged. It's awful. They're all taller than her. My daughter in heels. High up there. Nevertheless, this is kind of what it looks like. We'll talk about this area. Here's the shaft, the thickness of the compact bone. This is called, as you'll see shortly, the nutrient foramen. Not a big deal for us. That's what I mean. We are skilled in anatomy, particularly if you're going to work on bones, to avoid that, because you'll compromise the blood supply. The blood supply into the epiphyses has its own blood supply. I told all the classes, the best two-sport professional athlete I ever saw. I'm a sportsaholic for 70 years. A guy named Bo Jackson, who was not only an all-star an all-star MVP in football, he was an all-star MVP in baseball. Okay, how's that? Back in '88, he was one of the MVP and all-star. He a magnificent runner for the Raiders. What happened, he had what looked like an innocuous hit going out of bounds on his hip. And if you remember in the femur from anatomy, the head of the femur had a little indentation, a circular indentation. It's got a fancy name, fovea capitis femoris, which means the indentation in the head of the femur. Just sounds better in Latin. That's the blood supply of all that cartilage on that head. He underwent what was called avascular necrosis. The head effectively died. It flattened. In fact, never healed properly, ended his career. By the time he, maybe 10, 15 years later, had to have hip replacement early, mid-40s, which is early. A very, very successful, very, very bright guy from Auburn. Wife's a PhD from Auburn. I mean, very, very shrewd and intellectual, nice family. Named Bo Jackson. You can look him up. Just remarkable athlete that's there. So that's why I'm saying that to you. There's a lot of interesting things, and I'll share some of this anecdotal stuff. I'll have one soon that I did to let you know just how strong certain things are. And we're really going to highlight this bit of tissue called the periosteum. The periosteum is really where bone takes its ability to heal. It's a sheath. It's not a flimsy sheath. It's a thick, strong sheath made of the same material that the dense, deeper dermis is made out of. Dense, irregular connective tissue. The same thing that the capsule around your knee and your shoulder is made out of. Extremely strong stuff. And the interior lining has all of these wonderful cells that allow bone to heal. Most of the healing of a bone, most of the remodeling of bone comes from that exterior area. That's where it changes its shape, it thickens. And again, all of you, if I didn't tell you already, I should. The bones you are born with are long gone. It's not like they get bigger and stay there forever. Most of you have replaced your entire skeleton twice. Your bones are constantly being remodeled, whether you're using them or not. And the more you use them, the more remodeling that goes on. The more you build up, the more you break down. All of the forces are on. It's a very, very, very famous term that we go into probably in the next couple of talks. Wolff's law. Bone forms as to the forces that are on it. If you're, for instance, if somebody had a stroke and they got a contracture, they couldn't. And that's why we try so hard to limit contractures, hold them, embrace them like that. The bones adapt to that position because it doesn't move enough. And that's what I worked on a lot with arthritic individuals. They couldn't move effectively, they limited the range of motion, the bones adapted. We have to go in and cut the bone to reposition the cartilage of the joint. Forward facing, and then put pins, wires, screws, whatever was necessary to hold it in place. Yes?
To be honest, so the next time I'm not doing this, but whenever you were in school and took anatomy, what did you do to study? Like, genuinely? Because, like, the way that you talk about it, you know absolutely everything. Like, I don't understand.
Okay. Okay. Did you get what I was talking about with the way I'm describing that? Very good question. That's the kind I want to know. I'm a bad example. I have such a good memory. I have almost photographic memory for images, particularly for images. I can flash like that stuff. So I'm a bad. A lot of them. I think it's just continually going over it and quizzing each other about pointing to. Listen to what my study guide is and I like a combination of individual and team study. And if team study is going to work right, you got to make sure somebody on the team is higher ed. Somebody's doing pretty well and getting it. That would really help. Yes.
I also have a you're saying that the parents is like really strong. Is there any like it's getting strong for it? I don't have to speak it, but like I don't know. You said it's like it's strong.
Yeah. It's like a sheath.
Oh, that's what I was asking.
It's like a sheath. It would be hard to, like, if you and I could play tug of war on it, probably not going to tear. What we do in surgery, we cut it. We carefully lift it off the bone, peel it off the bone with a special instrument, and at the end, do all the work and sew it back together. And rely on all the cells as we're going to describe in here. Does that help you with the studying thing? And that's what I mean for anybody, and not just anybody who just because they asked a question. Come and show me how you're doing the study. Make it a point. Well, we can do it virtually, online. Tuesdays and Thursdays I'm not here. truth be told, it's very hard for me to do. I do so much in the days that I'm here. My age, I need recovery days, and they understand that. I was blessed. You can't make the memory up; it just comes to you. My dad had it. It was better. It used to be better years ago. It was semi-photographic. Hey, if you got an edge, you use it. You learn that in life. If you have it, don't feel self-conscious about using an advantage that you have. You know, whatever that might be. We'll sometimes feel, just to get where you want to go. I don't, I hate it when people, their idea of success is they have to succeed and you have to fail. I'm offended by that. My idea of success is I want to succeed, but I want everyone else to succeed. I was good with this stuff when I was in school. I'm with a bunch of other doctors trying to learn an anatomy. The way they learned anatomy, I would teach it to them. I had already had it. The way they learned bio, the course that we're here before is chemistry. We did biochemistry. I have 6 or 7, and they were all guys coming over. We only had one gal in our class. It's 50 years ago or more. And I'd sit there and teach this stuff to them. I never had to study. I was teaching them. There's an old saying, if you're in a medical field or a scientific field, particularly medical, see one, do one, teach one. It works. Do it all the time. Like, okay, that's an IV. Watch me start it. Now, your turn. Now show somebody else. See one, do one. This is what this is at the joint level, the cartilage, okay? Very, very thin cortical bone, a whole lot of spongy bone. Okay. The periosteum, strong. Outer fibrous layer, dense, irregular, very strong. Inner layer, all these cells that make bone cells. Not all of them. I'm not worried about osteoprogenitor cells or anything like that, or osteogenic layer like that. Just to know that these are cells that are going to make other bones that are there. And this is where when you break a bone, it's not the interior of the bone. It's very, very few sensory fibers. It comes from tearing this pulling away off the bone, swelling that underneath it begins to, that irritates it. That's where the pain comes from. It may surprise you. I had a patient who was bad diabetic with no sensation. I was operating on his bone without any anesthesia. He's no longer with us. His neuropathy was so bad, he had no sensation below his knee. None. I mean, he could feel me pulling and tugging on the bone. Any anesthesia. Other things that are important about it. The perforating fibers, if you go forward, I'll show you. This stuff, how strong is that stuff? It's immensely powerful. Okay? Look at this. Okay. I told the other classes an anecdote. This is the material, these perforating fibers. They have a fancy name. They're called Sharpey's fibers. Capital SHARPEY apostrophe S. I don't think it's printed anywhere. I sent you a study guide, by the way. Okay, I posted the study guides for the next exam because I wanted to get people starting early. I understand if you can't get it until you're done with lab. I understand. And I did a case at where the Penguins play. It used to be a hospital. It's old St. Francis Central. I did a case of orthopedic surgeon. This gal had a bone that was in 2 pieces in her foot in the navicular. You might remember that from lab. The posterior tibial tendon was there. We had to detach the tendon, take the tendon off the fragment that we had to remove because her foot couldn't function properly, and reinsert it. We couldn't just sew it into the bone. We had to take a special device. It was like a polypropylene, a high-density plastic plug, because the body won't gobble it up, won't view it as foreign. Drilled a hole into the bone, stuck the tip of the plug in, twisted it, and when you twisted it, out came 3 little fish hooks made of stainless steel that you pull back on like a grappling hook, if you know what that is, to hold and secure it. And then coming out of the stem, not the stem, but the head, were 2 laces made of a particular suture material. And we'd actually crisscross suture the way we tie a figure skater or a hockey skater. Do that. And that's to mimic Mother Nature and these fibers That's what we had to do to reattach a tendon. Same thing you would do if you had to reattach if the Achilles tendon got pulled out of the calcaneum. Because that's what he had done with it. And it was a friend of mine who had a lot of experience. He actually a relative of my first wife. And so that's just part of what's going on here. So as we move on with this, there is some lining on the inside that's called endosteum. That's where I make sure I have everything done. Okay, very delicate, not a lot of healing. Yes, some bone cells on the interior that are there. The nutrient arteries and veins, big deal. There's the nutrient foramen, the opening. It's the main blood supply to the bone. And the separate ones and they form after. Biologically, in development, the shaft develops first. This is really important forensically. When we get skeletal remains is it a child? How old is the child? Is it a small adult or is it really a child? We look to see if there are growth plates. We like to see which bones have growth plates and don't have growth plates. I'm speaking the medical or forensic community. I am not part of it, but I had a fairly good introduction to that during my years. I was board certified in orthopedics. You're supposed to know some of this stuff. That was a long time and kept that up for 25 years. So epiphyseal arteries and veins, they come afterwards that are there. And that was the illustration I showed you before. We know this is part of there. You're using the humerus. Very, very thick cortically, comparatively just a little of this cancellous bone they're trying to demonstrate there. And again, I think it's a really good illustration for those fibers. This is what I told you about this. The hematopoietic tissue is something you really talk about in blood. I don't really want to go into it crazy here. I mean, this is really down the road, depending on who's doing AP2, you'll find out more about it. And it's there, so there's not a lot to say. And this you all did in lab. Don't do any of that. Goodbye. No more foramina. Sorry to report.
So that's
Not going to be on. Oh, that's lab. I don't want to know your trochanter from your tuberosity. Okay, amen. You all say amen. So the lining around that bone, underneath it, the cells, they come from a stem cell line. Fibroblasts, chondroblasts, making fibers, making cartilage, making bone, all the same cell. Magically, they can, depending on, when you break a bone, it doesn't magically put bone in there. And we're going to see this. It starts with fibrous tissue. The fibrous tissue converts to callus. Then the callus becomes bone. It's all the same cell. It starts as a fibroblast. Then it converts into a chondroblast. Then it converts into an osteoblast. So a stem cell is something that's these osteoprogenitor cells have the potential to be all of these things. Very versatile. The big player is the osteoblast. So when bone is remodeling, growing, all of a sudden you got a job like many of you are aspiring to do, where you have to stand up all day on a clinical floor. Not fun. Okay? The bones in your lower extremity are going to thicken around the shaft. Okay? Those osteoblasts are going to be particularly busy based on how you bear weight and making that shaft extremely dense and comparatively thick. Those are osteoblasts. Blast means they're busy making matrix, and the matrix consists of a ground substance that's a protein that attracts calcium and collagen fibers. The only fibers that are in the bone are collagen fibers. Sharpie's fibers or those perforating fibers, collagen fibers. Just a slightly different way that they're sort of manufactured. When they're as the protein attacks calcium from the bloodstream, and again, has a tremendous blood supply, what happens is it begins to firm up, and the cell becomes less active from a variety of chemical signals and becomes, for lack of a better term, somewhat bound or entrapped for the time being. At that point, the signals basically say you don't have to do as much work. You can make a little, you can get rid of a little. I mean, it's like an on-off switch, and it becomes what we call an osteocyte. the implication is it's still a living cell, but it's considerably less active vis-a-vis production of the ground substance in the matrix. We always use, I'm sure you got it in lab, they call it a lacuna, because cartilage and bone cells, very similar, they have a little enclosure. People erroneously think this is like a hollow space and the cells in there. It's more likely an optical illusion from the way that the sections are stained. And a lot of what we see microscopically is that. It's the cells in there, it's not a blank space. It's not like you're all sitting in chairs, we have a big room of empty space around it. No. Things are filled in. But what happens is it gets entrapped, and you'll see the illustration. This is what the osteoblast looks like, very indistinct. This is the progenitor. What happens, it looks, these tentacles aren't really there. It's just that osteoblast with stuff forming around it, and some of the cytoplasm, the membrane gets entrapped. And you have these sort of tentacle-like projections, and they communicate with each other cell. They're touching the other cells. And they can either send chemical signals, they have gap junctions to transmit the signals, chemical and electrical signals. So they're communicating, okay, he's at the gym again. We got to make more bone. So you better change from osteocyte back to osteoblast. Or, oh, thank goodness he stopped doing that. He's taking a break from that. We could, maybe hurt himself. Sorry to hear. But now we don't have to be as busy. Do you get the idea? Anthropomorphize the bone. Make it seem like it is living. Cells talk to each other, but with chemicals. And then, so as I back up to, I want to be as clear as I can. I know I jump around. I'm trying to do my stream of consciousness lectures. So the osteocytes, bone cells in the lacuna, they're not dividing, but they can morph, they can change, okay, respond to different stimuli or weightlessness. And every so often, they'll tell other cells to make more bone. And the osteoclast is the oddball. It's not really a bone cell. It's a white blood cell that's kind of like a group of macrophages. And what they do, they're the ones that gobble up bone. When they get out of hand, we have a disease that most people get by the time they're an older adult called osteoporosis. If you live long enough, you're going to get it. Don't worry. Okay, some people get it much earlier. It's like cataracts, same deal. My mom was having cataract surgery. I had an ophthalmology appointment. Honest story. I said, I'm really worried. My mom, she's about 77, her cataract's done. And he's she's doing my eyes. He says, you don't have to worry. I said, I'm not going to get cataracts. He goes, no, you live long enough, you're going to get them. Gee, thanks. Truth, absolutely true. You say I changed ophthalmologists. My insurance changed, so I saw somebody different. So effectively, the osteoclast, when you have clasis, it means to destroy something. So osteoclasts secrete chemicals that break down the bone, and they're working all the time because bone is a bank for calcium, and we use calcium in everything. Calcium make nerves work, they make muscles work, they make blood clot, they make the heart work, they do all of those things. So we're constantly putting calcium, extra calcium in bone, and pulling it out. The osteoclasts secrete chemicals, and we'll go over how they go about doing it. They're triggered by something that's in another lecture. We have like 2 or 3 more topics after this, 3 I think, that begin to talk about hormonal controls, something called parathyroid hormone, how vitamin D interacts with it, how we raise and lower the amount of calcium that we need, either pulling it out of the bone or putting it back in the bone. It's like a bank account, really, what it is. And the lining cells, we really don't understand, so I'm not even going into them. And these are the osteoclasts. They're an interesting cell because they are a multinucleus. It's like a confluence of multiple cells. They have these things called ruffled borders. That is about surface area, so they can impact large portions of the bone. So this is what they look like, osteoclasts. You can see 1, 2, 3, 4, 5, 6 in this illustration. But it could be certainly more cells that have formed a sort of a big, kind of a giant cell. A giant cell has a special meaning, and these are these ruffled borders, and they're in little areas called resorption bays. Again, a lot of our theory and our treatment about understanding about osteoporosis. When we get into osteoporosis at the end, people always thought, oh, the bone's losing calcium. No, it's losing bone substance and it's losing calcium also. So this is really the important part, this osteon. It consists of layers of bone. This is really the functional portion of bone. It's like this, okay? Each little, if you look at the bone, lamellar bone, I know I'm jumping ahead, but I want to show you an example. If you look at bone that looks like this, imagine that each one of these circular items is an osteon. It's what they are. So it's like, if I had one pencil, I could snap it, just like we're doing braids with braided proteins. If I had a handful of them and they were all taped together and I had sticky stuff holding them together, it'd be a lot. They'd give a little bit, but they wouldn't break. That's kind of what's happening. So the way they describe these osteons, and I'll back up, as pillars, and we call this layered bone. Another name is the Haversian. Some people say Haversham system. Either one's work. So elongated cylinders. The bone is layered, rings of collagen, and you'll see the design in a second. And those bone salts that are these mostly calcium phosphate, some magnesium phosphate, others maybe even and maybe even some calcium carbonate, but mostly calcium phosphate, get attracted, and it's this brilliant design biologically. So each ring has collagen fibers that go in opposite directions, counterclockwise, clockwise, counterclockwise, multiple rings, maybe a half dozen rings around a central canal that's filled with blood vessels and nerves. That's the beauty of the blood supply in bone. And so you have all of these pillars, they describe them as, an immense amount in compact bone, so powerful. They have additional blood supply. They have additional channels called Volkmann's or perforating canals that go in tangentially. That's a right angle. So they're going from outside to inside, pointing to the center. You're going to see the illustration next. I'll jump to that. Here you can see them. These are the central canals. Every one of these osteons has a central canal. Here's an actual micrograph where you can see the blood vessel. Coming off at right angles and going toward the marrow or the medullary canal, more blood supply. How do the cells talk to each other? Side to side. All these little threads that you probably saw in a micrograph, or if you saw it under a microscope, are called canaliculi, little canals. And they kind of go side to side so the cells can send information to one another. Very, very intricate, but as you can see, well understood. So there's the lacunae and the canaliculi, and basically this means of communication, and as well as it firms up, even though the cells are trapped, they still can send signals to one another, and there's enough space that nutrients and waste products can be distributed and eventually either gotten in or gotten out. So, I mean, it's underscoring circulation of the bone. When blood invades the cartilaginous shell, the cartilage dies, and we start to form this remarkable structure. Just remarkable. And I've had some experience. I've done some bone grafting. You put bone in. It was always bone from the same person. Sort of borrowed it from point A and brought it to point B, because you're not going to reject your own bone. And these are, when we talk about what holds it in place, interstitial lamellae are like little bits of similar tissue that act as glue in between the pillars. Circumferential lamellae are sort of the band that would be like you took duct tape and wrapped it around. And so you can see it's just so interesting. Here they are. From the outer aspect of periosteum, you have the circumferential layers or lamellae. And then you have here these little bits in between. Those are the interstitial lamellae. So you should be familiar with both of those. And the spongy bone, which just looks like this sort of helter-skelter bit of like a honeycomb, the reality is it's designed for stress. It's how we identify stress fractures in bone. The analogy of cables on a suspension bridge, very good to explain the way that is. You don't see the osteons, but again, it facilitates a lot of surface area, particularly for blood formation when it's used that way. And they show you that same illustration you saw before. The organic components are called osteoid. That is the collagen fibers. And those calcium attracting proteins. The inorganic is the calcium salts, calcium phosphate, magnesium phosphate, maybe some calcium carbonate. Look at this. This is the amazing thing. With the right proportions, you could take a metal testing device and have a tube of steel and a bone, and if you compress what it took to fragment and shatter the steel, compress it till it broke apart, half of that pressure, the bone would still be intact. And if you applied a twisting moment to them, and there's machines, when I started Lehigh, they had metallurgy testing, they help metallurgical engineers. They take metals and they pull them apart, push them together. I wasn't an engineer, but it's a neat thing to watch. As strong as steel. As strong. So go out after today's presentation and thank your bones today. Have a glass of milk if you're not lactose intolerant. You're almost done. You don't have to. I could. It's like my wife laughing at me yesterday. She indicates to me periodically I'm talking out of my posterior. She used a different terminology. So osteoid about 1/3 of the weight. The calcium salts, which are made, they have a fancy name you're going to see in a second. This hydroxyapatite. Remember that? About 2/3 of the weight. Because the crystals, they form this very interesting network. That's why the name is important, and obviously talked about after death, looking at skeletal remains, et cetera, et cetera. Quick backup. Oops, wrong way. Almost done. Sacrificial bonds. Like anything in the body, we have so many mechanisms that help us from hurting ourselves. This is a good one. How many times have you been in a hurry to run someplace and you kind of twisted something, maybe caught an ankle, missed a step, and it was pretty forceful, and you go, it didn't break. So lucky. Those are sacrificial bonds. In between those osteons, little bonds form. When that impact of twisting, they'll break, and once the force goes away, they'll reset. So they're sacrificing themselves, albeit temporarily, for you to be able to function. The good, I mean, that's good news by and large. Unfortunately, from a clinical standpoint, a really bad sprain is a whole lot harder to treat than a fairly simple fracture. Because again, bone heal fairly simply. So we always talked about that, those high ankle sprains, and I'll identify what those look like when we get to the next chapter, which is all about joints and arthritis. And so that's really everything. Again, we're going to look at how it works with hormones, and we're going to see how bone elongates in growing bone. Then we have a unit on fractures, and then we have a unit on osteoporosis, and we're done with bone. And that is the end of material, most likely before the next exam. Thank you. Please, questions, please work with me. I will work with you. Thank you very much.
Okay, so I changed the way that I was taking notes because I realized that just typing the notes wasn't helping me. So I got this thing where I can write what you're saying.